Hello, everybody. Welcome to day 2 of Reflux Awareness Week or GERD Awareness Week. Today, we're going to be talking about the workup for reflux. We talked about reflux yesterday, about what it is. We talked about what the what causes it. We talked about the bottom of the esophagus and breakdown of those things, and we're going to kind of go through the ideas. If somebody were to present to their doctor for reflux, what's going to happen? So, for most people, they present to their doctor. The doctor, they say, "Hey, doc, I've got a bunch of reflux, a heartburn. It's really bad." They get some medicines, and a lot of patients, they get the medicines and they're on them for the rest of their lives. Well, there's some patients that the medicines don't work. They stop working. They don't have the effect that they're supposed to have. So they keep on going up and going up, going up, and they get to that point where like I can't get any relief from this. No matter what I do, no matter what I eat, something's causing me a problem. Or I'm just having too many breakthrough symptoms. Sometimes it's great, but it just is too bad. Anyway, whatever your situation is, you say, "Yeah, I'm gonna go to the next level and get worked up for reflux." So a lot of patients end up going to gastroenterologist for reflux management, and gastroenterologists will oftentimes recommend an EGD. An EGD is a camera study that looks inside the esophagus. Goes down inside the esophagus right through here, takes a look at the bottom of the esophagus, and takes a look at the stomach. We can do biopsies, we can take a look around, we can see if there's anything that helps us understand what's causing the symptoms. At the same time, the practitioner would place a Bravo capsule. A Bravo capsule is a special technology that allows the measurement of reflux down at the bottom of the esophagus, but it's able to do it without any wires sticking in your nose or anything else like that. This little represented purple thing is an introducer, and it puts the green thing, which the device is actually not green, but puts this green thing in the esophagus and leaves it there. And then when it's in the esophagus, it's able to communicate how much acid is actually coming up into the esophagus. And it communicates it to a little pager that the patient is carrying. This is great because it gives us an actual number. Your reflux is this bad versus, this bad. And that lets us know what, the kind of grade how bad it is and what kind of steps might need to be taken based on how bad it is. I guess most important is it gives us a hard number. Well, one of the other studies that gets done prior to any full evaluation of the esophagus is something called manometry. The manometry is a test that it measures the strength of the esophageal squeeze. It's this little catheter represented by the line with blue dots, and the blue dots represent pressure sensors. And they put it through the nose down into the esophagus, and the esophagus will squeeze on it while the patient is swallowing fluid. And that squeeze is measured by our little computer, and then it processes it and gives a special report. And it's important to know how the esophagus is working, because if the esophagus isn't working the right way, that can contribute to reflux. If it's working too hard, squeezing too hard, that can contribute as well, and it contribute to pain. Most importantly, this test is needed when someone is considering surgery, because then the esophageal squeeze determines what procedures can be done by a surgeon. Another study, one of the last 3 that's done as kind of the reflux workup process, is called a barium swallow. The barium swallow is when you drink a barium that is called radio opaque, meaning when you take an x-ray, it shows up. And so we can see the esophagus all the way down through. We can see the stomach, these little small folds right here, that's the stomach. This is a pretty normal esophagus. So if this patient, if you were to have reflux, sometimes you can see the barium coming up. If you were to have a hiatal hernia, you could have some of the hernia popping up here. So all these different studies, they help us identify if there's a hernia, how bad's the reflux, where's the reflux, and if there's anything that's causing it. Some of the things we find when we're going through this workup that require us to, advise different steps or kind of change what we're doing is one of them is called Barrett's esophagus. This is Barrett's esophagus, an example of it. So this light pink right here is a normal looking esophagus. This kind of darker pink here, what we call salmon color, is the Barrett's esophagus. So the Barrett's esophagus is when the reflux comes up in the esophagus and burns the esophagus so often, more or less, and I'm going to speak as if I'm the esophagus. The esophagus says, hey, I'm getting burned. I don't want to get burned anymore. And what it does is it reaches back in its DNA and says, hey, the intestines, they can take, acid goes into the intestines do okay with it. So let's change ourselves. Let's change ourselves from the esophageal lining into intestinal lining. And so it does a process called metaplasia, fancy term for it changes itself. It changes what it is, right? So the metaplasia or the change occurs and it converts itself from esophageal lining into intestinal lining. Cool, huh? Well, not so cool, because when that happens and it changes the way that it expresses its genes, it can change the way that it does everything. And when that happens too many times and in the wrong way, that's how cancer begins. What? Reflux is related to cancer? Yeah. Reflux is related to cancer. The Barrett's esophagus is believed to be a transitional step between no cancer and cancer. Does everybody that gets cancer have Barrett's esophagus? Not necessarily, but everyone that has Barrett's esophagus is at risk of developing cancer. Some of the things that are used to evaluate for Barrett's esophagus, and if there's esophageal change, is this wonderful thing called Watts 3D. Your GI doctor or surgeon who does your EGD can do this at the time of your procedure. And you can actually see some Barrett's esophagus in this picture. And this is a brush. This brush helps to brush on the Barrett's esophagus and gives us a better idea of how extensive the Barrett's is. If it is a whole lot, and how advanced. Is it really, like I mentioned, it can change how it does things. Is it changed just a little bit, or is it actually changed more towards cancer, or is it just halfway there? So there's these different terms we call dysplasia, or how bad it's changed. And this brush helps to identify more completely the extent of that. So we talked a bit about hiatal hernia, and let's touch on that again. Hiatal hernia is where, unlike a normal esophagus and stomach, where everything is below the diaphragm, a hiatal hernia is where part of the stomach slides up above the diaphragm. That hiatus, or that opening in the diaphragm, is where some of the stomach slides up. This paraesophageal hernia is just a different way where part of the stomach goes up through the diaphragm. Either way, something's wrong, something's not acting right, and the apparatus, or the hiatus, that hole in the esophagus, just is not the right size. It's too big, and something's going through there abnormally. So we talk about reflux can lead to cancer. Well, what if I don't need an EGD, or what if there's, for some reason I can't get insurance to pay for it, or I don't have time, or whatever it is. There is another test that can be done called the EsoGuard or EsoCheck. That is an in-office procedure. This thing looks really huge right here, but it's actually about that big. It's really tiny. In the office, you would swallow this down. We do some little, kind of do some things with the balloon and pull it out, and we can test your esophagus. And it's an in-office procedure, in-office test. You walk into the office, you sit down, we do this, and you stand up and walk out, 15 minutes, and you've got, and then we send it off to pathology, and then they tell us, is it positive or negative? Did you screen to say, yes, you need to have an EGD, or no, you're fine? This is a great tool, because if you're worried and you get it done and, hey, you're negative, perfect. If you do it and it says positive, then you go get an EGD, or you go get some sort of screening to say, hey, do I have that change at the bottom of my esophagus? And if you have that change, then then you'll go down that pathway and have further conversation. But anyway, so a couple things that are really, really good for us to understand that are out there to test our esophaguses for the changes that can happen because of reflux. Because nobody wants to be surprised by cancer. All right. Well, it's been my pleasure to talk to you guys, and I will check in with you again tomorrow when we talk about reflux medications. It'll be a little bit longer one, but I'm going to try to be as, I guess, break it down to talk about the way that they work kind of in normal everyday terminology. Have a great day.